Assalamu alaikum. Today we're going to have two lectures. The first lecture will be neuro-ophthalmology, which is this lecture. The second lecture will be about the optic nerve.
والبرزنتيشن دكتور يكون بعدين
What's that?
البرزنتيشن متى بيكون؟
Presentation after the lectures. I think Dr. Uthman. Anyway, the visual pathway and its lesions. The visual pathway consists of the optic nerves, then the optic chiasm, then the optic tracts, and the lateral geniculate bodies, then the optic radiations, then the occipital cortex. Now the optic nerves, the fibers of the optic nerve originate in the retina, in nerve fiber layer. Then the retina is divided into the temporal and nasal halves at the level of the fovea centralis. The optic nerves join the chiasma and the anterolateral ending. The optic chiasma, it's a flat band-like structure lying above the pituitary fossa. This is very important. This is very important that the optic chiasma is above the pituitary fossa, and we'll know this later. The optic chiasma, there is a semi-decussation of the nerve fibers, and we'll know what's this later in the optic nerve lecture. The nerve fibers from the nasal side of each retina cross over to the opposite side. The nerve fibers from the temporal side do not cross, but pass into optic tracts of the same side. So this is the semi-decussation, that the nasal side of each retina can cross to the opposite side. However, the temporal side will just continue to the same side. The optic tract. The optic tract originate from the posterior lateral angle of the optic chiasma. They are cylindrical bands running outwards and backwards to end in the lateral geniculate bodies. They consist temporal fibers of the same side and nasal fibers of the opposite side. So the nasal is almost always opposite, and the temporal is for the same side. The lateral geniculate bodies, these are oval structures situated at the posterior end of the optic tracts. The fibers of the optic tracts end in the lateral geniculate bodies, and new fibers of the optic radiations originate from them. The optic radiations, the nerve fibers, proceed backwards and medially as the optic radiations to terminate in the visual center situated in the occipital lobes. Then now the occipital cortex, it is situated above and below the calcaneal fissure in the occipital lobes, extending up to the occipital pole. So this is very important. Now this is the cone, then the bipolar, then the ganglion system. This is the first order neuron. Then the second order neuron will end up in the lateral geniculate body. Then the third order neuron will end up in the cerebral cortex. Lesions of the visual pathway usually cause defects in the visual fields and diminution of the visual acuity depending on the site of the lesion. Etiology. Lesions in the visual pathway may be commonly due to either trauma, like injury by falls on the back of the head, gunshot wounds, tumors like cerebral tumor, pituitary gland tumor, vascular lesion like aneurysms, atheroma of carotids, cerebral thrombosis, inflammations like meningitis, chronic arachnoiditis, encephalitis, degeneration like MS, multiple sclerosis, very important MS. So this is very important slide, and the next slide as well, because it will summarize the whole visual uh, lesions or visual pathway lesions. So these are the normal blind spots. The blind spot would represent the optic nerves in the visual field. So first lesion in the superior temporal retina causes corresponding field in the left nasal visual field. So retinal damage is always the opposite in the visual field. The superior is inferior, the nasal is temporal. So superior temporal retina will cause what? Inferior nasal visual field defect. So this is number one. The retina is always opposite. Number two, total blindness in the right eye, complete lesion of the. So الoptic nerve damage مثلا resection of the optic nerve or total damage of the optic nerve will cause complete blindness of the same eye or the same field. Right, left. So right optic nerve damage, complete damage, will cause right field damage. Complete طبعا damage. Number three, chiasmal lesion. chiasmal lesion هي number three. number three. number two اللي هي هنا right. number three اللي هي الكيازم. هذا الكيازم. This is the optic nerve. Now this is the optic nerve, optic chiasm, الoptic, then optic tracts. So chiasmal lesion اللي هي اللي in the middle will cause bitemporal hemianopia. Bitemporal hemianopia, and we said that the anatomy of the optic chiasm is very important. That is above the pituitary. And why? Because any pituitary tumors, like for example adenoma or craniopharyngioma of the pituitary gland, will cause this lesion, bitemporal hemianopia, because the tumor will press or compress this area, and it will cause this visual field defect, which is bitemporal hemianopia. So the patient will just see in the middle here. The temporal area will be defected. Four is the opposite. So right incongruous hemianopia due to a lesion of the left optic tract. So the optic tract is the opposite. This word is important. Incongruous, which means not the same. You can see that the defect here is not as the defect here. The more posterior the lesion, the more congruosity is there. So the more posterior the lesion, the more that the defect will be almost similar in each eye. So the optic tract is opposite. Left damage will cause right incongruous hemianopia or quadratopia, only quadrant. Number four. Number five, optic radiation. Left homonymous superior quadratube نفسها the same, is almost tract, radiation, الcortex is almost the same. يفرق اللي هو congruosity plus other symptoms or signs. So left homonymous superior quadratopia due to a lesion of inferior optic radiation in the right temporal. So temporal is superior. However, here Parietal is inferior. So temporal region is superior. That's why we call it pie in the sky. Pie in the sky, because it's almost the same as the shape of a pie, and it's superior. So the patient will see as a defect in the upper area, which that's why we call it pie in the sky. However, the parietal is inferior. So they are almost the same, only in the location. This one will be superior, this one will be inferior. This is the opposite, this is the opposite, this is chondrotopia, this is chondrotopia. Only this is superior, this is inferior. However, the congruosity is more here in the parietal. Now, this is congruous because it's the same. The shape here, similar to the shape here, not as this, not as this. This is the occipital because, as I said, the more the posterior, the more the congruosity, which is the similarity between the defects. Now, this is very important, very important. Right, homonymous hemianopia with macular sparing. The area here, the macula is spared. This is specific for the occipital cortex. For occipital cortex, the macular sparing. This is specific for occipital cortex damage. This is the same. Left optic nerve damage. This is chiasma, will give us hemianopia. This is the optic tract. Optic tracts will give us the contralateral homonymous hemianopia. This will give us from the parietal. As we say, the parietal is inferior. However, temporal is superior. All contralateral, except here is ipsilateral optic nerve. Pie in the sky is the temporal. This is the temporal. Macular sparing is the occipital cortex damage or lesion. So now amblyopia, there is a partial loss of sight in one or both eyes in the absence of ophthalmoscopic or other marked objective signs. It's basically a deprivation phenomenon whereby fixation reflexes are not developed. Etiology can be unilateral amblyopia, like congenital error in visual pathway. Suppression of the retinal image. High refractive error. It is curable with suitable spectacles or glasses in early life. It's very important that it should be corrected in early life. High refractive errors should be corrected in early life, or it will cause amblyopia. كسل العين يعني. Amblyopia is كسل العين. Retrobulbar neuritis can be bilateral amblyopia, toxic amblyopia, or hysteria. Amaurosis. There is complete loss of sight in one or eye in the absence of thermoscopic or other marked objective signs. Etiology, unilateral amaurosis, amaurosis fugax. There is sudden loss of vision due to embolization of retinal circulation. The episode lasts for a few minutes. Cardiovascular abnormalities such as valvular defect, arrhythmias, migraine. There may be vasospasm of retinal vessels. Gaze-evoked amaurosis, transient loss of vision occur in particular direction of eccentric gaze. Bilateral amaurosis, like in uremia, meningitis, encephalitis, hysteria, Leber congenital amaurosis, which is retinal aplasia. Now the pupils. The pupils, very important to know about the light reflex. The light reflex is mediated by the retinal photoreceptors and subverts by 4 neurons. The first sensory connects each retina with both pretectal nuclei in the midbrain at the level of the superior colliculi. Impulses originating from the nasal retina are conducted by fibers that decussate, as we mentioned. Nasal retina will decussate in the chiasm and pass up to the opposite optic tract to terminate in the contralateral pretectal nucleus. So النازل will decussate يعني ينعكس. The right will go to the left will go to the right. The temporal continue the same, the temporal continue to the same. Impulses originating in the temporal retina are conducted by uncrossed fibers, ipsilateral. Ipsilateral means the contralateral means the opposite. That terminate in the ipsilateral pretectal nucleus. Second, which is the internuclear, connects each pretectal nucleus to both Edinger-Westphal nuclei. The uniocular light stimulus evokes bilateral and symmetrical pupillary constriction. Damage to internuclear neurons is responsible for light near dissociation in neurocephalus and pinealomas. The third, preganglionic motor connects the Edinger-Westphal nucleus to the ciliary ganglion. The parasympathetic fibers pass through the oculomotor nerve, enter its region and reach the ciliary ganglion via the nerve to the inferior oblique muscle. The fourth, which is the postganglionic motor, leaves the ciliary ganglion and passes in the short ciliary nerves to innervate the sphincter pupil. The ciliary ganglion is located within the muscle cone just behind the globe. It should be noted that although the ciliary ganglion serves as a conduit for other nerve fibers, only the parasympathetic fibers synapse there. So this is the light stimuli. First, the light shined on the right pupil. Then the action potentials from the right eye, which is this eye, this is the right eye, reach both right and left pretectal nuclei. So the light, this is number one, will go to the right and left pretectal nuclei. Then the pretectal nuclei stimulate both sides of Edinger-Westphal nuclei, even though the light was perceived only in the right eye. So the right eye is the light is only in the right eye, but both nuclei of the right and the left will be stimulated. Then again, the right and left Edinger-Westphal nuclei will be stimulated. Then lastly, the right and left side of Edinger-Westphal nuclei generate action potentials through the right and the left oculomotor nerves. That's why both pupils are constricted. This is very important, very important. That's why both pupils are constricted, because the stimulation came from both nuclei. So even if you shine light only on one pupil, both pupils should constrict, not only one. So this is the nasal decussation. That's what we see. This is the nasal fibers. The nasal fibers. Here is the decussation. However, the temporal is the same. The temporal is the same. Is this clear? This is very important. You should know this very well, and the previous slides as well. Now we'll go to relative afferent pupillary defect. This is very important as well, which is the Marcus-Gunn pupil. A relative pupillary defect. Marcus-Gunn pupil is caused by an incomplete optic nerve lesion or severe retinal disease. but never by a dense cataract. Those who were with me this week and last week, I explained this very well to them. The clinical features are those of an amaurotic pupil, but more subtle. Thus, the pupils respond weakly to stimulation of the diseased eye and briskly to that of the normal eye. The difference between the pupillary reactions of the two eyes is highlighted by the swinging flashlight. This is a very important test, the swinging flashlight test. We'll see this next slides, in which the light source is alternatively switched from one eye to the other and back, one eye to the other and back, thus stimulating each eye in rapid succession. A right relative defect is characterized by the following. So now let's say that the right eye is defected. The right optic nerve is defective, for example. When the normal, which is the left eye, is stimulated, both pupil constricts لأنها normal. However, when the light is swung to the diseased right eye, the stimulus is delivered to the constriction mechanism is reduced and both pupils dilates. When we say dilate here, we mean that the pupil will go back to its normal size, not dilation as in Mydriatic effect or dilating drops. No, it's the normal because it was constricted here. Then it should be constricted again when you swung to the left, to the right, but the right is diseased, so the right will be returned to normal, which is dilate. Even the left eye will be the same. So when the normal left eye is again stimulated, both pupils constrict once more. When the diseased right eye is stimulated, both pupils dilate or go back to its normal size. I will show you a photo, it will be clear. So it should be remembered that in an afferent sensory lesion, the pupils are equal in size. Anisocoria, asymmetric pupil diameter, implies disease of the efferent motor nerve. And then sensory afferent, which is this, and motor, which is efferent. Afferent is the optic nerve. So this is very good photo. Now, started with the left eye. So the light is in the left, on the left eye. So the pupil is constricted in the left, the pupil is constricted on the right as well. Now, we say that the right eye is damaged. The right eye is damaged. The left eye is fine. Now we will shift to the left, to the right. This is the swinging flashlight test. The left eye is okay. The optic nerve is fine, but the optic nerve is damaged for some reason. Let's say. So when the light is shined in the left eye, both pupils will be constricted. However, if we shift it to the left, to the right eye, the pupil size will come back to normal in both eyes. Why? Because the receiver here is blocked. يعني as you're doing nothing. يعني كأنك ما في نور هنا at all. And the receiver here is damaged. So both pupils will be dilated or going back to its normal position. Then again, if we go to the left here, both pupils will be constricted because, as we said in the previous slide here, the nuclei will cause or stimulate both pupils. So if the receiver here is fine, the stimulation will go. But if the receiver here is damaged, اللي هو النيرف, خلاص هذا بيتقفل. no stimulation. That's why will be the efferent papillary defect. However, let's say the nerve damaged here. عندي هنا stimulation is lost or a receiver is lost اللي هو optic nerve, and we shift it to the left. the left will go and it will stimulate both eyes. That's why they will constrict in both pupils. And that's it. So this is the swinging flashlight. This is the afferent pupillary defect here. Afferent pupillary defect. Marcus gun. This is the Marcus gun here. If you shift from the left to the right, الديوريشن اللي هو وين تنتقل من العين اليسار إلى العين اليمين, the eye will be going back to normal. So if the pupil was, if the nerve was fine here, when you reach the right eye, it should constrict again, because while you shifting from the left to the right, البيبل صار لها شوي dilation. المفترض إذا وصلت لها و you shine the light, it should constrict back again. However, the receiver is bad, not optic nerve, not fine. So that's why it will complete to dilate to till it's. So this is the first light. Now and then another reflex, which is the near reflex. The near reflex, sign kinesis rather than a true reflex, is activated by what? Accommodation. It comprises accommodation because of the accommodation, convergence, and miss. So accommodation, reflex or near reflex is comprised of three things: accommodation, convergence, and meiosis. Now, an oculomotor nerve, the nuclear complex of the third oculomotor nerve, is situated in the midbrain at the level of superior colliculus. It's divided into two divisions, and then a superior division, which innervates the levator and superior rectus muscles. Inferior division innervates the medial, inferior rectus, inferior oblique muscles. The branch of the inferior oblique also contains preganglionic parasympathetic fibers from the Edinger-Westphal nucleus. It's very important. The Edinger-Westphal fibers, the parasympathetic fibers, تكون مع البرانش of the optic inferior oblique as well. So this is sphincter pupillae and ciliary muscles اللي parasympathetic will innervate sphincter pupil. So this is very important. هذه اللي هو الtests. This is the muscle test. This is the left eye. We always say look for the insertion. Look for the. So this is the which eye? This is the right eye. This is the right eye. You can know this from this. الكورنكل. هذا الليفت eye يعني هنا الأنف. Here the nose. Okay. So this is the right eye. This is the inferior oblique. We always look for what? We always look for the insertion. Insertion. This is inferior oblique position. This is هنا superior oblique. Superior oblique تمشي كذا تنتهي كذا. فهذا الانسيرشن حق الاوبليك السوبير اوبليك وهذا الانسيرشن حق الانفيريور اوبليك. So you always look for the insertion. Why? The insertion, the action of the muscle is in the insertion, always in the insertion, not in the origin. So superior rectus muscle, the main effect of the superior rectus is what? Is elevation. This is the primary. A medial inward. Outward is the lateral. Inferior rectus is depression. The superior rectus is elevation, and the secondary is what? Secondary, here you should know that this is for testing. الصور اللي انتم تشوفونها الآن, this is for testing, not for the action. This is the opposite, especially secondary muscles. This is very important. You should know this. يعني concentrate here now. الفوتو, this photo, what you seeing now, for example, this is a superior rectus, a right superior rectus. This is not the action. يعني this, the photo what's showing here, this is not the action of the superior rectus. No, this is the area where you should examine isolately for the superior rectus. يعني it means that this is the area where only the superior rectus acts. If the patient look up and to the right, you are examining only the superior rectus. If the patient look up and inward, you are only examining the inferior rectus, and so on. However, the action of the superior rectus is not up and out. No, it's the opposite. It's up and in. It's up and in. So adduction and elevation is the superior rectus muscle action. You should know this. However, for the examination, it should be this. This is the first way. The other way, which is this one, اللي هي الاتش. الاتش. Upward and outward, again, right superior rectus. Upward and inward, inferior oblique. Downward and out, inferior rectus. Inward and down is the superior oblique, medial rectus, and lateral rectus. Now, obliques is the opposite from its name. So superior oblique will do secondary. طبعا الاوبليكس المين او البرايمري action is torsion, يعني يلف it rotates, يعني not elevate or وين الكلام. it rotates يعني الآن عندنا حنا السوبيريور الأوبليك هنا it will end up so it will what? This will contract, this will contract, so it will pull like this. So this will cause what? In torsion. However, a superior oblique like this will pull الآي إذا صار عندي هنا contraction will pull I what? Extorsion. Intorsion لل superior oblique و intorsion للinferior oblique. This is the superior oblique, this is the inferior oblique. طبعا قلت لكم أنا مرة أخرى خليكم من الأسماء اللي هنا. This is only for examination, not for the action. يعني you should يعني المفترض أنكم ماخذينها في البيدياتري وماخذينها أيضا في الأناتومي first lecture. So this is how you examine muscles. You should know this very well. H. This one. Anyway, the following are potential causes of intracavernous nerve palsy: microvascular like diabetes, hypertension, pituitary apoplexy, miscellaneous pathologies such as aneurysms, meningioma, carotid. So these are the causes of third nerve palsy. Most commonly diabetes or hypertension. It can caused by tumors as well. So involvement or sparing of the pupil is the most important sign. يعني الآن عندنا الآن oculomotor nerve damage. Is it pupillary involving or pupillary sparing؟ يعني هل الpupil dilated or not? Because this is very important because it can be emergency. You should refer to neurosurgery if the pupil is involved. So this differentiates from surgical, from medical to surgical lesion. Surgical lesion اللي هي مثل الانيوريزم or a tumor, this will cause pupil involvement by what? By pressing the bile blood vessels and superficially located pupil fibers. I will show you a photo, it will be very clear. However, a medical lesion such as in hypertension or diabetes or spare the pupil, so the pupil will not be, well, the pupil will be completely normal. This is because the microangiopathy associated with the medical lesion involves the vasa nervorum, causing ischemia of the main tract, leaving the superficial pupillary fibers intact. Aneurysms of the posterior communicating artery at its junction with the internal carotid artery typically presents acutely as a pupil involving painful third nerve palsy. مثل الانيوريزم or a tumor, it will cause pupil involvement as well. Head trauma resulting in extradural subdural hematoma may cause a tentorial pressure cone with dermal herniation of the temporal lobe. This compresses the thin nerve and it passes over the tentorial edge, initially causing irritative meiosis followed by mydriasis and complete thin nerve passing. So this is it. Okay. This is it. Now, this is the third nerve. هذا الأصفر. This is the third nerve. Okay. الpupil fibers موجودة في third nerve superficially. So if there is any aneurysm like this is aneurysm. If there is any aneurysm, any tumor, any hemorrhage, any hematoma, this will cause pressure here. The superficial fibers is for the pupil. So if the superficial fibers is compressed, the pupil will be affected. If there is no aneurysm, no tumor, no nothing, there will be only damage to the nerve by itself, like in diabetes and hypertension. So only the main trunk will be damaged. The pupil will not be involved. The pupil will be completely normal. This will be medical treatment. However, here, like in this aneurysm اللي هو انتفاخ، يعني انتفاخ in this artery. هذا الانتفاخ مو طبيعي الانيوريزم، هذا جديد انتفخ. Or if there is tumor or so, this should be managed by neurosurgery. This is emergency. So a pupil will tell you if the case is emergency or you can just observe. Again, here, blood vessels on pia mater supply surface of the nerve, including pupillary fibers. So pupillary fibers is in اللي هو surface damaged by any compressive lesions, like زي ما شفنا إذا كان في مثلا aneurysm or tumor or hematoma, this will compress the pupillary fibers. Vasa nervorum supply part of the nerve but not البيبل اللي هي in the middle يعني, but not pupillary fibers. This will be damaged by medical lesions. So if we have diabetes or hypertension or so, it will cause only damage here. So it will cause only motor defect, no pupil. Pupil will be spared. However, if we have aneurysm or tumors, this will compress the whole nerve, especially the superficial fibers اللي هي it will supply pupil, so it will cause pupil. Signs, partial involvement will give a milder degree of ophthalmoplegia. Ophthalmoplegia is paralysis يعني of the movement. The other cranial nerves and peripheral nervous system should always be examined. Any ocular nerve damage, you should always examine the يعني you should always do nervous system examination اللي هو other cranial nerves should be examined, and you should do sensory everything. Yeah, you should do nervous system examination. Profound ptosis, هذه signs. Profound ptosis due to weakness of the levator. So عندنا إذا كان عندي oculomotor damage, any oculomotor action will be lost. Levator lost, فيصير عندي ptosis. Abduction and depression in the primary position. يعني primary position eye will be abducted يعني to out and depressed. ليش؟ لأن عندي lost اللي هو superior rectus راحت. superior rectus راحت والmedial rectus أيضا lost. Due to unopposed action of the lateral rectus and superior oblique. Lateral rectus will be fine لأنها supplied, lateral rectus supplied by what? Abducens. Superior oblique by the fourth. Question here. Include superior and inferior divisions. Yes, it can include both divisions and it can include only one division. It depends. And you can see both, you can see only one. The intact superior rectus muscle also causes intorsion of the eye at rest, which increases on attempted illness. Normal abduction, because the lateral rectus is fine. Limited adduction and the recti is weakened. Limited elevation due to superior rectus and inferior oblique. Limited depression because the inferior rectus is damaged. Dilated pupil and defective accommodation due to parasympathetic pulse. هذه this is very important. قلنا هذه is very important. Why؟ هذه طبعا مو always. هذه إذا كانت dilated this is معناته emergency، يعني عندي مشكلة سواء كانت aneurysm or tumor or so. It can be there or it cannot be there. It depends على الكوز. لكن إذا كان عندك ocular third nerve palsy plus dilated pupil, this is emergency. This is how it looks. كذا البرايم بوزيشن. عندي مشكلة في الرايت اي. توسس complete توسس لأن third nerve damage، فالليفيتر اللي هي مسؤولة عن elevation of the eyelids lost، فيصير عنده توسس. B. This is primary position. This is how it looks. This is how it looks downward and outward. لأن عندي lateral rectus وعندي superior oblique لسه يعملون، فبالتالي this is how the normal position will look, or primary position. This is the primary position, down and out. In C, this is the right gaze, will be fine. الادكشن اللي هو outward movement will be fine. Why؟ لأن عندي lateral rectus is okay. So normal abduction is fine. However, الادكشن اللي هو inward، يعني when he looks inward it will be limited. Why؟ لأن عند الميديال rectus is damaged. يعني every muscle supplied by the third will be damaged. Adduction will be damaged. However, abduction will be normal. This is normal. E. An elevation, of course, will be limited, and superior rectus will be damaged. Inferior oblique will be damaged. A depression again will be limited because the inferior rectus is damaged. So investigation, vascular risk factor assessment. If the clinical features are suspicious of an expanding aneurysm, or if there is marked pupillary involvement due CT angio or MRI brain and orbit with venography. Treatment observation is usually appropriate in prescient macrovascular cases. The majority will resolve over weeks or months. However, urgent referral to neurosurgery if there was space-occupying lesion or aneurysm, and I know this by what? The pupil. اللي قلناها 100 مرة if it's spared or involved. هذه الأكشن مهمة جدا of the superior oblique والinferior oblique. You should know this very well. As we said, عندنا primary عندنا secondary action. So السuperior oblique، هذه superior oblique هنا تنتهي، ف it will what if this is pulled you should say see what، يعني الآن تخيل أن هذه المصل انتهت هنا الانسيرشن. If this contracts this should go like this، صح؟ يعني it will what entorsion تصير encyclotorsion. لأن عندي هذه المصل، تخيل أن المصل هذه انسحبت، فإذا انسحبت العين بيصير لها كذا الحركة entorsion. This is the primary. Obliques torsion movement، torsion always torsion. الopposite في الopposite here هذه الأوبليك هنا الانسيرشن. Let's say this will be pulled. contraction يعني pulling، تصغر المصل فبتتحرك العين كذا. X cyclotorsion. العين تتحرك للخارج، بينما السوبيريور اوبليك العين تتحرك للداخل. انتورشن. اكستورشن الانفيريور اوبليك. This is the primary. Torsion is the primary. لا تحفظها، افهم الاناتومي. if you know the anatomy you should know the movement. لأن الاناتومي here superior oblique is here, so superior oblique is here. So when the muscle contracts, the eye should contort simply. Inferior oblique is here. If the eye is pulled or the inferior oblique is pulled, the eye should extort، يعني بتتحرك كذا. السوبيريور اوبليك بتتحرك كذا. انتورشن. عندي secondary اللي هو depression or elevation. السوبيريور oblique will cause depression. الانفيريور oblique will cause elevation. This is the اللي I mentioned اللي هي opposite, not as superior rectus والinferior rectus. Superior oblique will cause depression. Inferior oblique will cause elevation. Now adduction. الأوبليكس both will cause abduction. هذا اللي كنت أقول لكم الصورة ذيك حق ترى التستنج not the action. الأكشن ترى شوي تختلف عن صورة التستنج اللي فوق. فالأوبليكس will cause abduction. both the inferior and superior oblique will cause abduction. So any oblique will cause abduction. any rectus اللي هو superior rectus والinferior rectus will cause adduction يعني inward. عندنا trochlear nerve اللي هو الفورث cranial nerve which will supply only the superior oblique muscle. It's very long and cylinder nerve, increasing its vulnerability for what? For trauma. So it's one of the most common nerve damage after trauma. Causes of isolated forenerve, it can be idiopathic, it can be trauma, which is the most one of the most common causes for the fourth. Microvascular tumors and aneurysms. Signs of left trochlear nerve. Left hypertrophy, limitation of left depression. يعني actions of the left superior oblique will be what? Will be lost. Superior rectus will cause what? Depression. صح؟ فراح عندي depression فصار عندي شوي left hypertrophy. Limitation of left depression أني راحت superior oblique. Left extorsion. Why? Here. لأن superior oblique will cause intorsion. That's why we'll have here extortion. Normal abduction. لأن عندي we have lateral rectus والinferior oblique. They do abduction. Normal elevation ما لها، بالعكس ما لها علاقة، لأن superior oblique يعني it will not cause elevation at all. فالelevation will be intact عند superior rectus وعند inferior oblique. So a compensatory, this is very important here. This point is very important. Compensatory head posture to avoid diplopia, double vision, vertical, torsional, and wards on down gaze. To compensate for weakness of intorsion, there is contralateral head tilt to the right. So left hypertrophy. And we said إذا كان عندي left trochlear nerve palsy, we will have left hypertrophy. Hypertrophy which means hypertrophy ترى يعني be careful here. هذا مقصود فيها مو hyperopia، مو مقصود فيها بعد النظر، مقصود فيها hypertrophy. It means the globe will be up. ليش؟ لأن عندي المصل superior oblique one of its is what? Depression. صح؟ فإذا راح عندي هذا الأكشن شوية الاليفيشن بيصير أقوى في العين هذه. فالبرايمري position of this eye will be hypertrophy مقصود فيها elevation will be slightly elevated، لأن one of the muscles المسؤولة عن الدبريشن راحت، اللي هي السوبيريور اوبليك، اللي تعتبر مسؤولة عن الدبريشن بشكل ضعيف، بس ستيل يفرق. لو راح فيصير عندي شوية خلل في الوزنية، فيصير فيه slight hypertropia or elevation. This is very important اللي هو compensatory. Always any posture، دائما any posture head posture أو كذا دائما تكون تعويضية للمصل، دائما تعويضية للأكشن of the muscle or action of the lost muscle. This is always. Why? To avoid الديبلوبيا. إذا كانت الدمج سيفير بيصير عندي ديبلوبيا، لأن حركة شكل العين بيصير مختلف، أو وزنية العينين بتصير مختلفة، يعني واحدة من العينين بتصير أعلى من الأخرى، فيكون عنده double vision. To avoid this he should do compensatory head posture على الأكشن، كأنه يعوض الأكشن of the lost muscle. الحين بنشوف صورة ونفهم. Now هذا البرايمري بوزيشن، هذا اللي قلنا الليفت هايبرتروبيا عندي. ليش؟ لأن عندي left fourth nerve palsy. فيو كان سي هير عندي السكليرال slightly scleral show، فمعناته عندي الليفت eye is slightly elevated because of the lost superior oblique action. B. Increase in left hypertropia on right gaze due to left inferior oblique overaction. ليش؟ لأن عنده هنا left inferior oblique overaction، لأن العدوها اللي هو superior oblique is not there، فماخذ راحتها بزيادة left oblique left inferior oblique، فيصير عندي overaction. بدل ما يصير look straight it will be look up. هذا inferior oblique overaction. C. limitation in left depression. limitation in left depression. قاعد يقيس لك هو، احنا قلنا الاتش صح؟ قلنا الاتش صح ولا لا؟ فهي واضح ان في complete limitation هنا. الاتش هنا هذه يكون عندي limitation هنا اللي هي هذه. This is it. Now عندنا دي normal left abduction، ما لها علاقة. الابدكشن is okay. normal elevation again is fine، لأن كل شيء مسؤول عن elevation will be complete or fine. Now this is the head posture. This is the head posture صح؟ Now عندنا compensatory head posture in the left fourth nerve palsy. head tilt يعني يميل راسه، يميل الراس، يعطيني ايش؟ لانه تمييله الراس هذه بهذه الجهه تعطينا ايش؟ تعطينا intorsion. تعطينا intorsion اللي هي ايش؟ المين اكشن هير of the superior oblique intorsion. يعني الجسم يفهم ترى من نفسه، يعني الجسم بيعطيك الاكشن of the lost muscle. السوبيريور oblique here is lost. ف this patient is doing head tilt، لانه لو حرك راسه لهذه الجهه بحركه العين تتحرك العين معه، فبتعطيها intorsion. ف this will avoid the diplopia. However with time بيصير عنده neck problem. So this is not ideal. This is not normal. Compensatory head posture in the left fourth nerve palsy. Head tilt to the right, face turn to the right, and chin is depressed. يعني يعطيك الأكشن of the superior oblique. However, the most important is the head tilt. Abducens, this is very always opposite head tilt. Yes. لأنه intorsion، أنت تبغى intorsion. الفورث always opposite. Yes. يعني لو كان عندي مشكلة هنا بيصير الهيد تلت هنا، لو كان عندي مشكلة في الليفت بيصير الهيد تلت كذا. يعطيك الأكشن أو المصل intorsion، يعني يبغى يسوي intorsion. أنت إذا حركت رأسك كذا، إذا سويت تلت أنت قاعد تسوي intorsion. هو ما لف يمين، ما حرك راسه يمين، يعني ما التفت يمين، لا هو لف راسه هنا، يعني هاي قاعدة تلف فيه، ما راح كذا مستقيم، لا لفها. فاللفة this is intorsion. Abduction is very easy. It's only for the lateral. only for the lateral rectus muscle. Signs of abducens يعني كأنك you are losing كان ما في lateral يعني كان ما في lateral rectus muscle. يصير عنده ايزوتروبيا، عنده limitation في الابدكشن، normal adduction ما لها علاقة، compensatory head face turn. Now this is face turn, not tilt. Face turn. Face turn toward the side of the paralyzed muscle in the unilateral. صح؟ Now الآن we'll see. Now let's say عندي left abducent nerve. لو كان عندي left abducent nerve, I will have what? I will have slightly left iso. صح؟ لأن left muscle, left lateral muscle will be lost. صح؟ فإذا في primary position I may have what? I may have diplopia. I should do what? I should do right face turn. Oh, sorry, left face turn. Left face turn. Because if I did left face turn, the eye will always be looking to the right side. صح ولا أنت يعني تخيل معي الآن عندك let's say إنه عندك أنت الآن left أو somebody has left abducent nerve, بيصير عنده left esotropia. صح في primary position يعني right eye. خلني أرسم لك إياها. هذه الليفت وهذه الرايت. صح؟ عندي انا الليفت هذه فيها مشكله اللي هو الابديوسنت. ف الاي will be like this وهنا الاي will be central. هذه بتصير خلينا نقربها اكثر بتصير like this يعني ايزو. هذه الاي بتصير ايزو، هذه الاي will be fine. صح؟ فthis patient اللي هو عنده ال left, if he looked to the left, the primary position will be يعني انت يعني الان تبي تحاول تخلي النورمال position في الايزو of the left. ف if you did face turn to the left side اللي هو toward the area or side اللي فيها الدمج, the eye will always be in the esotropia. انت يعني you are aiming as a patient or as اللي عندك left abducent, you are aiming in a diseased eye or diseased position will always be in the esotropia لأنه you cannot say out, you cannot see outward يعني you cannot do abduction. yeah excellent صح بالضبط. يلف وجهه يسار إلى أن عينه تناظر يمين فقط. صح excellent. This is the idea. So he will just do left face turn لأنه هو ما يناظر إلا toward the esotropia side. فبيحرك راسه لهذه الجهة الفيس لأن العين عنده ما تتحرك للخارج، ما تتحرك للخارج هنا، فدائما بيخلي النورمال بوزيشن في الايزوتروبيا وهذه بتصير هنا. يعني again after الفيس تيرن هذا بعد ما يسوي الفيس تيرن الليفت فيس تيرن صارت العين هنا هذه اليسار والعين اليمين اللي هي نورمال هنا. واضح؟ لأنه سوى فيس تيرن فصار نورمال عنده خلاص، صار الفيجن از فاين. however في البرايمري بوزيشن هذه العينين هذا خشم، هذه بتصير كذا وهذه بتصير بالنص كلير، فيصير عنده دبل فيجن هنا. this is the primary، بيكون البرايمري هنا بيصير عنده دبل فيجن. بالليفت فيس تيرن الدبل فيجن will be improved لأنها راحت اللي هو البيبلز كلها صارت in the same direction، مو بواحدة في النص واحدة isotropic. now here is obvious إن عنده left. how can you know if it's left or not؟ يعني إذا كان عندك شوي صعوبة في تحديد ال position of the eye, you can know this by what؟ شوف الرفلكس you can see the pupillary reflex. The pupillary reflex is fine here. However, a pupillary reflex is not fine. This means this eye فيها slight esotropia. معناته عندي مشكلة هنا، عندي مشكلة في اللاترال. فthis patient is looking now here. This patient is looking this side. فعنده defect في this eye. عنده defect في left abduced. Limitation of the left abduction. فعندي left في sixth nerve palsy. However في C normal adduction. أنت يعني الليفت اللي هو الفيس ليفت اللي قاعد نشرحها تو، أنت بيكون بهذه الصورة، مو بهذه الصورة الإكستريم، بس يعني تبيها سلايد يعني مو في النورمال بوزيشن، ما تبيها تصير بهذه الصورة، لا تبيها يعني شوية مايلين هنا وشوية مايلين هنا، بحيث إنه إذا كان في ديبلوبيا يختفي. Clear? So this is the first lecture. Any question? Is it clear? We'll just take 5 minutes or so.